I would like to thank Dr. Raman for inviting me for this instruction course. I'll be talking about anterior segment ocular manifestations and their management in the HIV patients. Now, the objectives are that there should be a knowledge of common anterior segment pathologies which we see in the AIDS patients, and we should know the common clinical manifestations of ocular diseases and how they differ from presentation in a normal patient or non-HIV patients and diagnostic difficulties in some of these patients. Also, the outline of management for the above in view of the HIV positive status of these patients. Now, what is the effect of AIDS on ocular lesions, ocular pathologies? They can have varied manifestations. The patients are predisposed to opportunistic infections. There may be atypical presentations. There may be abnormal age groups. Something which is seen at the older age is presenting in much younger individuals and vice versa. Rare malignancy may come forth, for example, Kaposi sarcoma. The disease may have a very severe course rather than having a more subdued course in a normal patient. There may be multiple infections or polymicrobial infections, and more importantly also there may be resistance to treatment, or there may be frequent relapses, so we need to just keep a watch on these patients. So if you look at the prevalence of the anterior segment pathologies, roughly around 7% of HIV patients have been found in one of the series to show some kind of anterior segment disease. Now, the CD4 count also has a predictive value when it comes to patients with some anterior segment problems. I'm sure Dr. Raman will address the posterior segment problems as well. So, when it comes to seroconversion, basically patients may just have uncomfortable eyes, inflamed conjunctiva, dry eye, allergic conjunctivitis. However, as the CD4 count goes down to less than 500, patients may have a very resistant type of dry eye, blepharitis and dermatitis, bacterial and follicular conjunctivitis, Kaposi sarcoma, molluscum contagiosum, and the ocular surface neoplasia. Along with that, there is increased propensity for developing herpes zoster and herpes simplex. And later on in the disease, we know that ocular lymphomas become more common, and lymphomas by and large become more common in HIV patients, and severe keratoconjunctivitis sicca, and other opportunistic infections and tumors. So, if we look at the skin and adnexal lesions, it includes molluscum contagiosum, herpes zoster ophthalmicus, Kaposi sarcoma, a conjunctival macrovasculopathy, amongst others. So, molluscum contagiosum is a pink or pearly white wart-like nodules on the skin. It affects 5 to 20% of HIV-infected patients. Incubation time is fairly long, 6 to 8 weeks, and it is more common in children and young adults. How it differs in an HIV-positive patient is that the lesions become much larger in number and size. They may become confluent, they may have superadded infection, they may be bilateral, and they may be resistant to treatment. And typically, a chin strap distribution has been described in these patients, and they may manifest fairly early in age. So maybe it's not a bad idea for a patient with having more lesions of molluscum contagiosum to get an HIV test done. So management is with topical chemotherapy and incision with or without curettage, excision, cryotherapy. More importantly, the heart therapy. Patients who are on heart therapy, this may act against the molluscum contagiosum and act as a treatment for that as well. So the prevalence of molluscum contagiosum has actually gone down in patients on heart therapy. Patients may come with multiple abscesses of the eyelid and the conjunctiva, or some dermal abscesses. The patients may develop atopic dermatitis, a very recalcitrant blepharitis, lid ulceration, which has been reported as a presenting feature of HIV. However, it's not so common. But yes, any patient who comes with recurrent episodes and resistant to treatment of blepharitis, maybe we should get an HIV done if it's in the high risk group. Trichomegaly or hypertrichosis, this is an exaggerated growth of eyelashes. Nobody knows why it happens, but this is a late manifestation in HIV patients. Very thick eyelashes are seen in these patients. Then conjunctival and eyelid lymphoma. This occurs more commonly in patients with CD4 counts less than 50, and besides the normal lesions of lymphoma like salmon patch or the conjunctiva, others, there may be rapidly progressive erythematous lead lesions. And also it has been noted patients who have a very resistant keratoconjunctivitis sicca, which is just not resolving, may actually turn out to be a lymphoma. Also, we should see that patients who are accompanied by ptosis, these lesions may be accompanied by ptosis, proptosis, gaze palsies, ophthalmoplasia, and other lesions which are common with ocular lymphoma. A non-specific conjunctivitis is rare, seen in less than 1% of the patients. Important is that if it's just not resolving, sometimes it may be due to cytomegalovirus or a cryptococcus. Conjunctival microvasculopathy has been described in up to 70 to 80% of the patients. This manifests as like some kind of segmental narrowing or some cattle trucking, slowing down of the blood column of the conjunctiva. The etiology is said to be maybe the increased plasma viscosity, or there may be an endothelitis of the conjunctival vasculature or immune complex deposition. Then the ocular Kaposi sarcoma. Now this is a highly vascular mesenchymal tumor almost exclusively seen in AIDS patients. Kaposi sarcoma is the commonest anterior segment lesion in AIDS, and 20% is associated with HIV patients. Now how it appears is a multiple violaceous or purple or red nodules, and it involves the eyelids, conjunctiva, rarely the orbit. The primary lesion is symptomless. It doesn't really cause any irritation except for the fact or the mass effect of the lesion. It is very rare in the Indian subcontinent, and it is postulated that it is because it's caused by herpes simplex virus 8, which is rare in the Indian subcontinent. This sarcoma is also rare in these patients. So the primary goal of therapy is palliation when the disease is disfiguring, painful, or interfering with function. Radiotherapy is the mainstay. We might try cryotherapy, chemotherapy, or surgical excision if the lesion is small. Now, dry eye or keratoconjunctivitis sicca, very common, occurs in 20 to 40% of HIV positive hosts in later stages. So, this is a later manifestation, is more common, severe dry eye. And the mechanism is said to be there's a destruction of the lacrimal glands by the lymphocytic infiltration, or it's also said to be active destruction of the glands by the HIV virus. So, the patients present with burning, uncomfortable red eyes. The patient is just not able to open his eyes. He'll just keep squeezing shut. And there may be corneal thinning and perforation may occur in these patients. So, talking about infections in an HIV patient, it has been shown that the incidence of infections is not very different in HIV positive versus HIV negative, but some features may be different. It may be bilateral in these patients. Polymicrobial infections may occur in these patients. There is a much higher risk of perforation. And we should keep in mind other etiological agents like Neisseria or microsporidia, and syphilis. If there's some syphilitic lesions like gamma, chancres, whatever, it frequently indicates a co-infection with HIV. And another feature about fungal keratitis, we know that fungal keratitis is usually accompanied by some kind of a predisposing factor, trauma or something. But in these patients, a spontaneous fungal keratitis, especially because of some candida species, may occur in these patients. Now, microsporidial keratoconjunctivitis has also been reported. Now, it's not very frequent in the common general population. Features remain similar, having multiple nummular opacities all over the cornea. Patient is extremely symptomatic. And in these patients, management is also done in a similar way, but this is also seen more in HIV patients. Now, very important entity is herpes zoster ophthalmicus. Now, this is a vesiculo-bulbous rash over the distribution of ophthalmic branch of the trigeminal nerve. 5 to 15% of the patients may be co-infected with HIV, and it may be associated with dendritiform or stromal keratitis, conjunctivitis, blepharitis, uveitis with secondary glaucoma, hemorrhagic hypopion, or scleritis, or of course retinitis and encephalitis. Now, in HIV, in one of the series in Africa, they found 100% of herpes zoster ophthalmicus patients younger than 47 years old were positive for HIV antibodies. And in another American study, they found patients less than 45 years, 61% was positive for HIV. What I want to stress is young patients, herpes zoster, get an HIV done. Then the relative risk for HZO in HIV positive is versus negative is 1 to 6.6. And how it differs is it may require prolonged therapy, it can recur frequently, it is more severe. Corneal lesions are seen in 89% of the patients versus 65%. There's a longer duration of the post-herpetic neuralgia, which may be very severe, higher incidence of ocular complications, including perforation, and the viremia which occurs may lead to other complications, systemic, like visceral or neurological complications in these patients. If you look at the HZO epithelial keratitis, it is typically pleomorphic, multiple with thickened opaque epithelium. The dendrites may be delicate and lacy rather than the coarse dendrites, and may be accompanied by PUK in these patients. Management is more prolonged. Intravenous acyclovir can be given, preferred for 7 days, and then oral maintenance regimen for 3 to 6 weeks, which is much longer than in a normal HZO patient. Now, early initiation of systemic antiviral therapy can certainly reduce the duration of the skin lesions and ocular complications by as much as 50%. Herpes simplex epithelial keratitis, we know it's a typical dendritic ulcer, we know what it looks like, but in this case, if you see a patient with a marginal dendritic ulcer, multifocal, many dendrites, or patients having recurrences and showing the longer healing time, so they may be tested for HIV. And there's a lower incidence of stromal herpes, because stromal herpes is an immune-mediated complication of herpes, and that is, we know the immune mechanism goes down in a patient of HIV. Management is the same as that for a normal dendritic ulcer. CMV keratitis has been reported. It's uncommon epithelial and stromal keratitis. There may be stromal corneal endothelial deposits in a linear or stellate lesion in up to 80% of the eyes with CMV retinitis. And excuse me, and may be associated with sectoral iris atrophy or secondary glaucoma. Now, I came across an interesting report. PUK, 3 patients of herpes zoster ophthalmicus had peripheral ulcerative keratitis. The important thing is that despite the treatment, one had bilateral progressive outer retinal necrosis and lethal encephalitis developed and the patient expired. So maybe PUK HZO is a bad sign in these patients. Talking about surface neoplasia, squamous cell carcinoma of the conjunctiva is the 3rd most common neoplasm associated with HIV after Kaposi's sarcoma and lymphoma. It may be due to interaction between the HIV and the sunlight and the human papilloma virus. And some of the features more common in these patients, 90% are cornea ovarian, limbal squamous cell carcinoma, very fast growth rate, or tumors which are larger in size. There may be changes in the color, including pigmentation of the lesion, nasal location. So these are features which may lead us to think that maybe this patient has an HIV. A deep invasion and metastasis, however, are rare in these patients. Also, if there's a lesion at the limbus, we can perform a gonioscopy to see that there's no intraocular invasion of this tumor. So management remains the same, and heart therapy is curative. So they think like, okay, maybe antiviral therapy works so well in treating patients of squamous cell carcinoma. Now, one of these studies, very interesting. Now, if you look at these features, raised lesion, leukoplakia, pigmentation, irregular borders, vascular abnormalities, so these are typical features. And if you see, all the 5 features were present in close to 70% of the patients who had HIV, versus just about 20% of the patients who were HIV negative. So maybe if we see a classical squamous cell carcinoma, maybe we should certainly get an HIV done in these patients. Also, if you see the response to treatment, so if you see in the HIV negative patients, just by the 2nd course of therapy with 5-fluorouracil, patients had responded, and it took a longer time in patients who were HIV positive. So another study noted that 7.8% of 409 screened HIV positive individuals, they showed the presence of squamous cell carcinoma. So maybe that is the prevalence in the HIV patients. Some of the iatrogenic or post-treatment manifestations, Stevens-Johnson syndrome can occur in these patients due to maybe all the drugs that the patient is taking. Some kind of drug deposition can also occur, which is called the corneal phospholipidosis, which can occur in these patients. So to conclude, several anterior segment manifestations in an HIV positive patient may be the first presenting feature to the ophthalmologist and lead to the diagnosis of AIDS in the patient. You may save the life of the patient actually. And HIV positivity leads to severe and atypical, often prolonged ocular anterior segment diseases. And adequate treatment may at least minimize the effect of that disease, and we can improve the quality of life of that patient. There's nothing more we can do, but at least this can be done for these patients. Thank you very much.